Hello, my name is Dr. Amir Mehran. I'm a bariatric surgeon and founder of the University Bariatrics Program in Thousand Oaks, California, and the co-director for the Center for Weight Loss Surgery at Los Robos Hospital. The purpose of this presentation is towards the patients who currently have adjustable bands, known as the lap band or the Realize band. There's some important information that I think you folks should know, and I would like to share them with you in the next 10 minutes. The adjustable bands, also known as the lap band or Realize band, are one of the 4 available bariatric surgery operations here in the United States. The other 3 are the staple procedures, such as the biliopancreatic diversion duodenal switch, the Rowan-White gastric bypass, and the vertical sleeve gastrectomy. On the scale of things, the staple procedures, such as the diversion, bypass, and sleeve, tend to have a slightly higher risk profile, but they're also more effective versus the adjustable bands, which have a lower initial risk profile, but also have a lesser efficacy. The upper gastrointestinal anatomy consists of the esophagus that comes through the diaphragm, as shown in this picture, and attaches to the stomach. The lap band is placed just at or a little below where the gastroesophageal junction is. Part of the band is a long tube that goes inside your abdomen and then connects to a port shown with a flash mark there. That port is attached to your abdominal wall using sutures or staples and is buried underneath the skin. And it's used to have periodic adjustments where needles are placed inside the port, and they are sometimes done with x-rays, sometimes without x-ray or ultrasound, and you have fluid put in or taken out depending on how you are doing. So the purpose of the port and the tubing is obviously to adjust the band, and that depends, as I said, on how you're doing. And if the band is too loose, it has to be tightened. If it's too tightened, you're having daily problems, then it has to be loosened. And it's a back and forth option that can be done every few months to as short as every few weeks, depending on patient's clinical findings. The adjustable bands are commonly known as lap band, but it's actually 2 different brands, the lap band and the Realize band. They came about as part of the bariatric surgery historical profile, some early to mid 1990s overseas. However, various iterations of the band did exist before that, back in the early 80s, and these were more fixed bands, known as the vertical banded gastroplasty, and another one, the Kuzmak band. The VBG operation eventually was found to be inferior to the gastric bypass in terms of weight loss results, and also there were issues and problems with the mesh or ring that was placed as part of the banded gastroplasty, and those problems persist even this far out, 20, 30 years later, and we still see these patients with having problems and require a reoperation. The Kuzmak band started here in Southern California, and it was a fixed band that was placed in the upper gastroesophageal region, but these very soon were running into problems such as severe complications related to the foreign body, and they soon fell out of favor. The adjustable bands were proposed subsequently, as I mentioned, early 1990s, and they were promoted because they had a soft balloon, they were adjustable, they were personalizable, and they were removable, the factors that did not exist with the previous iterations of bands. They also had no nutritional deficiencies associated with them, nor there were any issues with taking any certain form of medications, which is contraindicated with, for example, the gastric bypass. They are simple to do, easily trainable. You can learn them by taking a weekend course practically. They are done laparoscopically, and that's part of the reason that they became quite popular, mostly done as an outpatient with a very quick recovery. And when you compare it with the staple procedures, they definitely showed initially to have a lower risk profile. It became quite popular. A lot of programs, hospitals, surgery centers started to offer these. And these started popping up everywhere. This also led to a lot of billboard advertising, which was very common here in Southern California. Ads on buses, bus stop benches, and various other locations. This also inspired other, let's just say, proposals, such as shown here. And the net result was that the number of bands placed around the world, especially in the United States, rapidly rose. And you can see that in the dotted blue line, which obviously meant a huge financial boom to the two companies that manufactured them. But over time, the same issues that were seen overseas started to rise in the United States as well. This included a slower weight loss curve, in this case shown as percent body mass index loss per day. The need for frequent adjustments, 6 or more per year, to be able to lose the weight, with the issue also being that insurance did not cover all the adjustments. A lot of times patients have to pay out of pocket for it. The drop in the body mass index was lower with the band versus the gastric bypass, the sleeve, or the duodenal switch. Here in the United States, the same results going 10 years out, bypass weight loss better than bands. And folks who've had the gastric bypass tend to describe the weight loss as anywhere from good to exceptional versus band, which ranges from poor to good, and very few excellent. The lack of proper weight loss also meant non-resolution of the medical conditions for which the patients were having surgery, such as diabetes, blood pressure, reflux, etc. Unlike the staple procedures, where the resolution of medical issues seems to be independent of the amount of weight loss, that was not the case for bands. And that's also shown here versus the gastric bypass, where resolution of those issues is far better than bands. The other issue is obviously the rising rate of complications, slippages, erosions, infections, scarring, problems with esophageal outlet, problems with esophagitis, which can lead to Barrett's esophagitis, which is a pre-malignant condition. Over time, more and more reports and presentations were made, starting with overseas more, but also back in the centers which were the pioneers of doing these procedures in the United States, with the high rates of failures, reoperations, removals, and all kinds of problems. Over time, the odds of keeping the band keeps going down. This is also from overseas, 12 years out. And once again, the odds of keeping the band keeps going down and down, as shown in this slide here. For example, the bottom one, you can see that the bands that were placed back in 2000 to 2002, a lot of them are out already. So it's just really a matter of time. Then start coming the really bad news with the fact that these were not as safe as suggested. The various authorities, such as the medical board, started looking at it. It led to federal investigations, state investigations, all kinds of stuff. And it got to a point, got to a point where even the FDA got involved in this and started looking into it. And this is something that they don't do very often. And eventually what happened was that the manufacturers which were very hesitant to stop these deceptive marketing practices, to even stop selling the bands to them and to others similar to them. And what happened was that the number of cases that were done that was rapidly rising started to come down, once again shown in the dotted blue line, especially when the vertical sleeve gastrectomy started to show that it's a better operation. And I'm one of the small minority of surgeons which can now say, I told you so. A small group of us knew this would happen. We were watching what was going on overseas, and we knew that this was not in the best interest of patients, and we always told them that there are far better options that they should be considering, and not to give in to these kind of marketing and advertising by the manufacturers and the various marketing and medical groups. So now that you do have a band, now what? You're reading about it, you've heard about it, and I just showed you some of the effects of the band and what to look forward to coming down the pipeline. In very simple terms, I tell these patients to use it or lose it. Very simple. For this very small minority of patients which are doing very well, they're getting the proper follow-up, they're getting frequent adjustments, they're doing everything correctly, they're seeing dietitians and counselors, and they're well aware of the signs of complications, and they will present themselves to their physicians to assess them, and they're doing well from a nutritional standpoint. Keep the band. However, the overwhelming majority of the patients do not fall in that category. They're not getting followed up. They stop getting adjusted. They don't see dietitians, counselors, and they're having problems. Some of them daily, some of them silent, and they're unaware of it. And they've also picked up a maladaptive nutritional intake after the band is placed because of the problems they're having with the band. These include daily reflux, heartburn, food getting stuck, vomiting, dysphagia, which means pain on eating. You should not be having any of those problems. Patients should not be having chronic abdominal pain. They should not have problems with eating healthy foods, and they should not be reverting to high caloric liquids or junk food to maintain their sustenance. Patients with bands are at chronic continued risk exposure for slippage, erosions, infections, mechanical breakdowns, the esophageal problems that I told you, as well as the scarring that goes on with this foreign body sitting in the upper part of the stomach. The options are two. Have it removed, which is the recommended option, either with another procedure or as a standalone operation, which allows you to have bariatric surgery, another kind, in the future, or no additional bariatric surgeries if you should choose so. You can leave it in, which is not recommended unless it's, as I mentioned, being used, it's working, and again, that falls into a small category of patients. For folks who want to leave it in, but are also not really using it, do remember that it's just a matter of time. You're at a lifetime risk of compounding risks, and as complications go and as time passes, additional surgery becomes more difficult and more risky. Patients might say, well, if I have it undone and redone or something else done, sometimes the insurance doesn't cover it, and I will not be able to have another surgery once it's removed. That is not true. There are CPT codes, all kinds of them, for removal of bands and the port or bits and pieces of it. But the bottom line is that it's a very well accepted, well-known reoperation risk, and it is not an uncovered procedure. Health plans do cover it. Some folks say, well, I'll gain a lot of weight once it comes out and I can't lose it again. And as you guessed it, that is also incorrect. Some do gain weight back, some do not. They actually can revert back to eating properly and doing the things that they were not able to do before, now that this obstruction is taken out of the way, and they actually start losing weight on their own. So just because the band is removed does not mean that your weight is going to come back. Our recommendation is to really consider all your options, and you can do that by not only watching this video, but going to our website, watching more information, and then making an appointment to come see us. We'll fully evaluate you, discuss all your options with you, and then give you all the proper recommendations. And then it's your choice what you want to do at that point. There's really no pressure on you. And as you know, our recommendation is to remove it or use or lose it if you're not using it. But you do have other options available to you, and we'll freely discuss them with you at your appointment. I thank you for your time, and I hope to see you in our office very soon. Thank you.